Good morning, good afternoon, good evening, everyone. Thanks for joining us on this Tuesday VMR. Today we had two VMRs back to back. So thanks to everyone who are joining both the VMRs. We love your support which you are giving to us. And I'm so excited that today I'm getting the opportunity to discuss with my good friend Yusuf. I think I have discussed with him once before and it was a blast. So I'm looking forward to that. Today we have the pleasure of having Sherry with us. I think she has already presented two wonderful cases before. And last time I was just telling her in the back room that she had signed up to present the case once, and then I was going to be discussing on that day, but then somehow it couldn't work out. So today is probably that day that we will get to know that amazing case. So thank you so much, Sherry, for bringing a case to us. I also wanted to thank Hashir for helping with the scribing and I for helping with the teaching points. And maybe Yusuf, you want to say hi to us and get us started?
Yeah, hi everyone. I'm Youssef, one of the CP Solvers members. I work as a hospitalist in Atlanta, same as Sherry. So, Sherry, do you want to introduce yourself and tell everyone how you've been and how's your job been so far and all of that?
Yeah, sure. So, my name's Sherry. I did my residency at Piedmont Athens in internal medicine, and I decided to stay mainly at Piedmont Athens, but I have basic credential throughout all the Piedmont. So sometimes you may catch me in Atlanta or Noonan or something like that, which I'm doing now. I'm actually going to be going to work in about an hour or so. But I've been loving attending life. I feel like residency is just one of those things where you just have to go through it and then you see the other side. It's like literally the light at the tunnel, and then it just continues to get brighter as you get your own footing. So I really have been enjoying it. I really, really have. And just to see that I didn't feel scared or I didn't feel like any apprehensive. I just kind of just did my thing. So yeah, I'm loving it.
Yeah, that's so exciting. And it's always nice for trainees to learn, to listen to this and hear this, and there's a light at the end of the tunnel. And I just wanted to point out something that everyone watching us on YouTube, if anybody wants to present a case, you can just visit our website, clinicalproblemsolving.com. And then if you click on morning report and you scroll all the way down, you can click on present a case and then you can sign up. It can be a bread and butter case, a rare case, any of the above. We even had a case of a UTI a few weeks ago. So any topic is fine. We would love to like meet you and hear about your cases. So if everyone is ready, if you're ready, we can go ahead and start with the case.
All right. Okay, so should I go ahead and start talking? Okay, awesome. So I have a 58-year-old male who presented with unsteady gait. Would you like me to give you a little bit more information?
Just a little bit more. It sounds good.
Okay, sure. So he is a 58-year-old male, and he came in with unsteady gait with right lower extremity heaviness that had started about 3 weeks prior, and it's basically have become progressively worsened. He didn't have any other associated symptoms, but his main complaint is that he has had felt very heavy on his right side, specifically his right leg, which has caused him to have multiple falls without any trauma to his head.
Wonderful. Thank you so much, Sherry.
Mhm.
A neuro case. I love it. So this is sounds like a 58-year-old male who's having unsteady gait. And I use a similar framework to the one that Robbie uses, that imagine how hard it is to walk and think of all the processes needed to walk. And then think of a problem in any lesion in anywhere in the neuronal pathway towards walking, and that can cause you to have unsteady gait. And here, so I think about it could be sensory nerve going all the way up to the synapse, to the neuromuscular junction, all the way up to the CNS, and even to the motor pathways going down as well. So it can localize to anywhere along the pathway, and that can cause unsteady gait and falls. And falls is like commonly like a geriatric syndrome that can be multifactorial, and especially with unsteady gait as well. But here we hear that there might be some right lower limb heaviness. So I'm starting to try to localize the lesion. Could this lesion be at the nerve that's at the right lower extremity, or could this be in the CNS? We can't just know just from the history so far, but I'm intrigued to try to localize before doing the exam. I was trying to think of, am I gonna I'm gonna find lower motor neuron signs or upper motor neuron signs, and trying to find associated symptoms to try to localize the lesion before creating a problem representation. What do you think, Kirtan?
Perfect. Thank you so much, Yusuf. I love your approach that the first step is to localize the problem. And in neurology, we often run across this problem, right? We know that we have Occam's razor and then we have Hickham's dictum. Now, in neurology, the thing is that the axis is so big, starting from cortex all the way to the muscles, that often we try to come up with a single localization, but inevitably it might happen that people can have multiple localizations. So it's not unusual to have a problem in the spinal cord as well as the peripheral nerves, like you said. Now, one thing which I wanted to mention is that Dr. Barkovitz always teaches us that it's time course as well as localization, right? So if we focus on the time course in this case, this is kind of a subacute course. Now, usually the vascular events, be it ischemic stroke or hemorrhagic stroke, the general teaching is that the deficit is maximum at the onset itself, and it should not progress after weeks. It might progress in initial few hours, especially if the hemorrhage is expanding. But it's hard to imagine that somebody would have a vascular event and it keeps on progressing, because that's what Sherry told us, that it has been progressively getting worse. So at least that part we can keep at our back of our mind, that maybe it's less likely to be vascular event. The second thing that we have to characterize, that what does this heaviness mean? So as Yusuf was saying, that does it mean that patient is not able to feel it at all? So is it kind of numbness and sensory deficit, or heaviness as in there is a motor deficit and patient cannot seem to lift it up and that's why it seems heavy? So characterizing that will be crucial, because if we are localizing to motor pathway, then we think that, okay, is it possible that this person has something in the brain itself, which is contributing to the unsteady gait as well as the focal weakness in the right lower extremity? Because it is conceivable that maybe the patient has a mass in the motor cortex, which is explaining the weakness in the leg, and a second mass in the cerebellum, let's say, which is affecting the unsteady gait. Or it may not be a mass. It could be a demyelinating process. It could be a disseminated infection, like let's say abscess, or multiple AV malformations or things like that. So basically, we need to figure out that what is this heaviness stuff. And then if we go down the CNS axis, then I agree with Yusuf that this could be kind of like myeloradiculitis, which means that something is wrong with the spinal cord, like dorsal columns. That's why you have unsteadiness, as well as maybe the nerve roots itself. Because once you involve the nerve roots, let's say you involve the whole lumbosacral nerve roots on the right side, then that can give the total paralysis or the total weakness of the lower extremity, which might mimic a stroke. So that's why that will be my key focus, to figure out that what is this right lower extremity heaviness, so that I can map down the axis, that where is the location, and then we can talk about the differential. So excited to hear more from you, Sherry.
Yes, I think those are both great points. Another thing that I would like to add is just to add a little bit on the timing. The timing is very important as far as the management if you're suspecting that the patient has a stroke, because they could be a candidate for TPA or not, depending on what kind of stroke it is. So it's also very important. In this case, he's not a candidate, even if it was an issue of a stroke, because he's way um, out of the window. But it's always good to ask specifically if they can, or if any family members that are at bedside, if you have to get information from them in regards to would they be a candidate for TPA or not. So yeah, I think that was really good. As far as we can go into his past medical history. So his past medical history, he has hyperlipidemia, he has atrial fibrillation, and type 2 diabetes mellitus. The only medication that he takes is atorvastatin. For his diabetes, he's just lifestyle, he's pretty active. For his AFib, he just takes a baby aspirin. He's not on any like anticoagulation. And for his hyperlipidemia, as I said before, he's on Lipitor. So for his family history, not really anything specific that could add to this. In his social history, he's never smoked, he's never drank any alcohol, never done any recreational drugs, and he has no allergies. So when you look at the aliquot, when you're thinking of like CVA or something else going on, it also could be key of, okay, does this patient smoke, which increases risk for stroke? Would it be, does he use any recreational drugs? It also increases for like a subarachnoid hemorrhage if a patient is using cocaine, because at basically at any time, what was their blood pressure? Are they hypertensive? So it just helps you paint the picture in regards to management, especially as a nocturnist. You have to think on your toes a lot of the times, because you depending on where you are, you may or may not have all the specialties that you need in order to make the best decision for the patient. So it's always good to look at not only how they're presenting, the time frame, but also their risk factors.
Thank you so much,
So
Sherry, and
mhm,
thank you for
mhm.
teaching us as well while you're presenting the case. That is really awesome. Is there anything else you wanted to add on this aliquot, or should we go take a stab at it?
I think that was all for that aliquot. And then I can go into the vitals and the physical.
Okay, Kirtan, you want to go first?
Sure. Yeah. Well, so nothing much came from this aliquot, but at least what Sherry pointed out is very important, that we were able to rule out some of the key risk factors which we might have been looking into. Like, let's say if this person has been taking any over-the-counter medications, and those over-the-counter medications we know can have so many effects in the body. They can have anticholinergic effects, they can have sympathomimetic effects. Some of them can make your blood thin or thick, so they can have anticoagulation effect or hypercoagulable states which can present in weird ways, or they can have heavy metals, let's say. So Sherry told us no over-the-counter medications, so that part is out of the picture. Again, no substance abuse, no drugs, which is also reassuring. Now, all we know is that this person has type 2 diabetes mellitus. Now we know it's a very common thing, and we would be more interested to know that how bad or poorly controlled is the diabetes, because what we were initially talking about in first aliquot was that is there something wrong with the peripheral nerves or something wrong with the spinal cord which can affect your proprioception. And we know that diabetes can affect all of this in various ways. Like people can have diabetic neuropathy, which is very simple. Sometimes people can have diabetic lumbosacral plexopathy. People can have so-called diabetic amyotrophy. And diabetes also can, since it is affecting the large peripheral fibers, it will also affect the vibration and proprioception. And if this person has poorly controlled diabetes, then they can also have kind of microvascular infarcts in the brain. So that would be also one of the interesting points to know, that what has been going on in the brain. So we will like to get A1C, see how he has been doing. Apart from that, we will see what the examination shows, because still the money is in examination before we lay down our hypothesis about extended differentials. So maybe I can ask Yusuf that any other hypothesis that we should lay down as of now, Yusuf?
The only thing that came to my mind was that this patient has AFib, and automatically when I see any patient with AFib, I immediately calculate the CHADS VASC score. And this patient just gets 1 point for diabetes and doesn't get any other point because it doesn't have any, he's younger than 65, no other history of CVA or anything like that. So I'm trying to think in advance, like, oh, if this patient turned out to have a stroke, could we have prevented this? Well, technically, according to the guideline, if with a CHADS VASC of 1, he would be eligible for aspirin, but not necessarily a DOAC. Now the guidelines are changing, and now there are new therapies. So I don't know if you all have heard there's something called dual pathway inhibition. So now if somebody, for example, has peripheral vascular disease and AFib, sometimes they do low dose DOAC plus a platelet inhibitor at the same time. And this is, of course, all depends on risk benefit, but just based on the CHADS VASC score, this patient would only be eligible for aspirin, which he's already on. So that was my other thought as well.
Yes, that's a really good point, because I think anytime someone sees AFib, they automatically think, oh, this patient should be on Eliquis, or this patient should be on some type of anticoagulation. But you have to also do by clinical guidelines if this patient, yes, it may have been preventative if he had met the CHADS score requirements, but in his case, he didn't. He was just on baby aspirin. But that's also a good point as well. So I guess I'll jump into the vitals, into the physical exam. So his vital signs were pretty stable. His blood pressure was 140/80. and it didn't have any discrepancy as far as his right or left arm. His temperature was 98, his respiratory rate was 15, his pulse was 90, and his SpO2 is 100% on room air. But this is where the money is. Anytime you do a neuro, the physical exam can tell you basically a lot. So basically his physical exam is cardio, lung, abdomen, and he wasn't in any distress. All of that was within normal limits. But as far as his neuro exam, his cranial nerves 2 through 12 were intact bilaterally, and his strength in his upper extremities was 5 out of 5. But on the right lower extremity, it was about 3 out of 5 compared to the left, which was about 4 out of 5 or 5 out of 5. And when I was doing his finger to nose test, he was overshooting, and he was kind of like, when you stood him up, he kind of leaned towards, like he kept swaying to one side. So that also made me concerned for a possible upper motor neuron lesion or something else of that nature. In addition to that, when I did the hint test, I noticed that he had nystagmus that was vertical and it beat it up towards, versus like a horizontal or rotatory nystagmus, which will also tell you it's peripheral versus central. So with neuro, a lot of the things, the money, like as you guys said, the money is in the physical exam, and it also will help you with your management style and not only what tests to order, but what images to order to help you best differentiate what you see and help the patient.
Perfect. And Sherry, just quick clarification that any word on reflexes or tone, if you got a chance to do that?
So the reflexes were about 1+ bilaterally on the lower extremities and 2+ on the upper extremities. The tone was fine. He
Okay,
didn't have any
perfect.
issues. Mhm.
And as you said that the person was swaying, but even with the eyes open, so you never got a chance to do the rhombugs, right?
Mhm.
Okay, perfect. Thank you. Yusuf, you can take the first step.
Yeah, thank you, Sherry. So it sounds like the positive signs in this physical exam were maybe some dysmetria on finger to nose testing, some swaying towards the side, and weakness. And it sounds like maybe decreased reflexes in lower extremities, but the same bilaterally. The first thing that stuck out to me was could we localize this lesion to the cerebellum? And usually to differentiate between a cerebellum that is a medial lesion, like in the vermis or in the hemispheres. So in the vermis, I think of truncal ataxia and usually no limb ataxia and could have nystagmus, while any lesion in the hemisphere usually is associated with dysmetria, dysdiadochokinesia, and some dysarthria and sometimes a tremor as well. And then here it sounds like we have some leaning towards the side. So we have some ataxia and we have some dysmetria. So definitely it sounds good localized to the cerebellum. I'm not 100% sure if it is purely vermis versus hemisphere, although the differentiation here is purely semantic, because in real life we're gonna get an image and find out exactly where it is, and it could cover both indeed. The other thing to think of is we have this weakness in the lower extremity, and trying to think of how to combine both the cerebellar lesion, the cerebellar localization plus the weakness. Could there be a multiple lesions? That's like one hypothesis. And could there be, because in a patient with AFib, they're at higher risk for embolic vascular events. So that usually if the patient has these events, it will be more than one, so they can shower emboli into both the motor cortex and the cerebellum. The other thing I didn't mention as well was the nystagmus, but Kirtan can talk about that shortly in the HINTS exam portion. And then I'm not sure about the reflexes. It sounds like they're like downgoing. Sometimes with vascular lesions, they can start as the reflexes that can be decreased, but then they become increased. So that's my hypothesis. So I'm not putting a lot of extra money into it towards thinking about lower lesion of the nerves. What do you think, Kirtan?
All right, thank you so much, Yusuf. I agree. And I also wanted to highlight this that we are loving the teaching which Dr. Walls is giving us in between. It's like such a good way of learning through VMR. So thank you for that. So yes, like now we know that at least from the examination, the process being in the cerebral cortex, like the motor cortex, is less likely because firstly, if something is in the cerebral process at least for 3 weeks, it's unlikely that you will have hyporeflexia. That is kind of unusual. And just lower extremity, even the left lower extremity is fine. So just right lower extremity, it kinds of make you wonder if the problem is in the peripheral nerves or in the spinal cord itself, but not in the CNS, it's like cerebral cortex itself. That's one thing. The second thing, regarding the nystagmus. So now we know that the HINTS exam is very complicated and there like you need really a nice understanding of the various neurological concepts. But one very easy way out of HINTS exam is that if somebody clearly has vertical nystagmus, then that is kind of very sensitive for CNS involvement. Like it's very unusual to have somebody has vestibulocochlear nerve involvement or middle ear pathologist which is coming with vertical nystagmus. And so far from the history itself, like there is nothing to suggest that this person has vertigo, nothing to suggest that this person has hearing loss. So it's natural to think that this process is in the CNS itself. Now, where in the CNS would you localize nystagmus? Now, again, like there are so many centers in the brain which controls your eye movements, but the key things, at least the bird's eye view, should be brainstem, where multiple cranial nerve nuclei are there, and the cerebellum, because cerebellum will coordinate everything. So in this case, if we try to focus just on the right lower extremity, then we might be swayed because in somebody who has diabetes, and again, we are not sure how well controlled it is as of now, the peripheral nerves and spinal cord, the nerve roots could sway you away. But so the money is in the cerebellum because that is kind of more specific and more narrow differential. So we have to think that what can affect the cerebellum or brainstem in a subacute time course. And as always we do with any other differential diagnosis, it's easy to conceptualize if we break down in different buckets. So if we start with the easiest one, that what kind of infections can present in this manner. So you start with spirochetes like Lyme disease, syphilis, which we know can cause cerebellitis, can cause myeloradiculitis. So those will be the two things. The classic bacterial infections, less likely because we don't have fulminant presentation, we don't have fevers, we don't have constitutional symptoms. But what about indolent organisms? Is it possible that this person has mycobacterial infection? Definitely possible. What about endemic mycosis? That can also come like this. Then atypical bacteria, like let's say nocardia, let's say listeria. We know that nocardia, listeria, all of these organisms have tendency to affect the brain stem and base of the brain. So they can affect your cerebellum, they can affect your brain stem, and they can cause abscesses there and even secondary vascular events there. So that is one thing. What about viruses? So again, a big thing in any person with neurological problem, you want to get their HIV status, you want to get the hepatitis status. Because once you have HIV positive, the whole game will change. You will start endorsing possibility of cryptococcosis, toxoplasmosis, and the whole bucket opens up. So we would like to know that what's the HIV and syphilis status for sure. So that's about viruses. Parasites, very less likely because the time course is not making sense and we don't have any evidence yet, like let's say eosinophilia or travel to those countries. So that we will keep at the back of the mind. What about STLV? We know that STLV can cause myelopathy. And our dear friend Valeria has presented twice, I guess, on STLV myelopathy. And it can come at this age group. And so we would like to know what has been the status of STLV. This is about infections. What about autoimmune conditions? So we know that the big autoimmune conditions are demyelinating conditions like NMO, MOG, then GFAP, astrocytopathies. All of them can affect the multiple part of CNS axis. Sarcoidosis should be considered. SLE should be also considered because SLE can also cause cerebellitis and transverse myelitis. So this is about inflammatory demyelinating. And then we go to the rarer and rarer categories. Like what about paraneoplastic disorders? So we know that there are so many autoantibodies like anti-Yo, anti-TR, anti-HU antibodies, which are known to cause paraneoplastic cerebellar degeneration. And in particular, anti-HU antibody can also cause peripheral neuropathy. So that will be interesting to know that does this person have any evidence of demyelination in the spinal cord or in the cerebellum? Because then we would start thinking more about these autoantibodies. Then we come to the category of deposition disorders and kind of like paraproteinemias and stuff. So in fact, recently only I had this discussion with Yusuf regarding one of the cases which we had that is it possible that this person has, let's say, amyloidosis? And once you go into the category of paraproteinemias, the whole bucket opens up. There are like just alphabet soups of different disorders like Poem syndrome, Canomad syndrome, Canvas syndrome, Canda syndrome. Like basically, in whenever I am seeing C stands for cerebellum, and then everything else could be whatever. Some people can have nystagmus, some people can have ophthalmoplegia. So that's about protein deposition disorder. So we would like to know about the SPEP workup. Then tumors, like as Yusuf was saying that, what about multifocal? Like, is it possible this person has lymphomatous meningitis or carcinomatous meningitis? So you are infiltrating the dura of the spinal cord, hence affecting the nerves, as well as you are affecting the dura of cerebellum and brainstem, and hence causing those symptoms. So that's how we can tie in the malignancy. And lastly, we will talk about late onset genetic disorders and degenerative disorders. So we tend to think that genetic disorders should come at younger age, but we know that every disorders, depending on how many deletions you have, insertions you have, and how many copy number variations you have, can come at different times. So spinocerebellar ataxia, there are literally like 1 to 35 variants of SCA. Like I don't even remember that which variant causes what, but there are numerous spinocerebellar ataxias which can come after the age of 50. So SCA should be considered. Friedreich ataxia is another big one. We should never miss that. It can also present like this. So, and in the dystrophic and degenerative disorders is kind of earlier to say, but sometimes people can have rare versions of corticobasal syndrome, Creutzfeldt-Jakob disease, which can present like this. So these are the big buckets, but I guess once we get the imaging, then we can narrow down this big bucket into probably 5 to 6 disorders. So maybe I can ask Yusuf that what else we can think about.
Kirtan, that was amazing. That was like the infectious disease note that starts with "in brief" and goes on to list 700 causes of cerebellar disease. No, that was amazing. Kirtan, the only thing I wanted to ask you, so everyone on this call, everybody watching, is gonna order head imaging, and we're gonna get CT or MRI. We're getting there. In addition to that, what would you change, or what else would you want to know to change the differential? I think the things that I would want to know are an HIV status, the location that has the #1 new diagnosis of HIV in America is actually at Nana, it's Fulton County. And then the other thing would be the syphilis, the RPR, and the B12, which is the low-hanging fruit. Is there anything else, Kirtan, you would recommend for any case that presents like this, like to prevent missing anything major you could think of?
No, Yusuf, actually, I agree with you that apart from the basic workup like CBC, BMP, everyone will get, right? But yeah, HIV is the big one. And in case you are suspected, then maybe ESR CRP. I know it doesn't help in localizing, but ESR CRP being totally stone cold normal might make you think about like non-inflammatory conditions. So that's only other thing I will add.
Okay, awesome. And that was very impressive. That was awesome. But I guess I'll go to the basic labs first. So pretty much his labs were pretty stone cold normal. CBC, CMP, BMP, UDS, ETOH, HIV, RPR, negative, 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 negative. So at that point, we're like, okay, so where do we go from here? So as you know, like at night, the first thing you have to do is basically make sure that there's nothing acutely going on. So you do the fastest would be CT head without contrast. So when we got the CT head without contrast, it showed a mass in his brain near the parietal and temporal lobe, which was kind of interesting because of how he presented, didn't necessarily correlate. But when we followed up with the MRI, there were several masses all over the brain. And I followed up with the patient, and unfortunately, he was diagnosed with glioblastoma. So it goes to show you that, you know, sometimes people don't always show up like a textbook. You have to be able to differentiate. Okay, I know that he doesn't really have that much of, you know, past medical history other than diabetes. That's well controlled. His A1C was like 6. His labs are normal, but it goes back to what the patient presented. He presented with unsteady gait. So that automatically I'm thinking, okay, unsteady gait, what other symptoms is he having? Did he have a recent viral illness? Does he feel like he's dizzy? If he had a recent viral illness, is he having trouble breathing? Okay, am I thinking, and he's having bilateral lower extremity weakness that is upsending, is that GBS? If he's having dizziness, is it feel like the room is spinning? I would think of more of like Meniere's disease. Did he have a recent URI or some type of ear infection and he has ringing of his ears? Is it Meniere's disease? And you have older patients. In his case, he lived at home, but there are a lot of older patients that go to facilities and they're on like 20 different medications. So is it polypharmacy that's causing him to feel unsteady? You have a lot of things like the Beers list, which you should not give patients that are over a certain age, that will increase their risk of falls. You have to look at that. In his case, we didn't have that. What we had was his physical exam. And what his physical exam was, the most telling to me was the vertical nystagmus. I always thought of it in residency as the brain is going to tell you where the lesion is. So if the brain is doing rotary or horizontal nystagmus, that's pointing towards your periphery. But the second it moves up and it starts to beat up, that issue is in the brain. So I wanted, because it was at night, only thing I had was the CT head, and the CT head showed that there was one mass with edema, which also will change your management, because if there's edema, you want to give steroids. So in order to decrease the edema, the vasogenic edema. And then when we did the MRI, there were masses everywhere. In the cerebellum, there was in the temporal parietal lobe, and when they did the cytology, he had glioblastoma. So yeah.
Scary. Thank you so much for sharing this amazing case. Wow. And what happened to the patient? How did they find out about the diagnosis? And were there any cerebellar lesions? Do you remember? If not, it's okay.
I don't remember if there were cerebellar lesions, but they did the cytology report on him, and he did he went to IR, did LP, and then they did the cytology, and the cytology basically showed that he had glioblastoma, and so they put him on Keppra, and they basically said he had, I think it was grade 4 glioblastoma.
Wow, wow, what a fascinating case. And do you know what happened to the patient? Like, did they get better, or you're not sure?
This was actually not that far from now. So I'm not 100% sure what happened since then, but yeah, it was very interesting as well.
Oh, well, thank you so much for sharing. Kirtan, do you have any reflections?
Perfect. No, I mean, it's sad for the patient, but hopefully they get the right treatment and they get better. But this case also proves that why it's so important to have the framework. Like literally in the first aliquot itself, we were discussing that where would you localize, and we were saying Occam's razor, Hickham's dictum, and we said right that inevitably it is possible that maybe it's not one lesion, it's multiple lesions, like maybe a mass in the cerebellum, mass in the spinal cord, mass in the main cortex itself. So unfortunately, that is what happened to this patient. And like in older people, when we see the multiple brain masses, often we think that it has to be the mets, because that is how the brain works, that most neoplasms are neoplastic, but I mean are metastatic. And it's similar to the liver lesions. If you think about it, if somebody has multiple liver lesions, you would not think of hepatocellular carcinoma, but you would think that maybe this person has mets from the colon or from the stomach. But once in a while, you get multifocal HCC. So same concept applies actually for glioblastoma multiforme. It's one of those rare tumors. Like it's very hard to have oligodendroglioma, which is everywhere. It's hard to have astrocytoma, which is everywhere. But glioblastoma multiforme is the only kind of, how to say, exception, that it could be primary CNS neoplasm, but still it could present in different locations. So which is also consistent with our case. And nowadays, we have so much therapeutic advances that people have been able to discover the mutations in the glioblastoma multiforme. Like some people have IDH mutations, like isocitrate dehydrogenase mutations. And whenever I did my onc rotations, there were so many people who were on IDH inhibitors, and they do get a good response. So hopefully this person eventually, when they did the biopsy, they did the molecular profiling, and they could have found some mutations which they could target. And it's hard to imagine that how can all of these lesions will vanish one day. But the goal is not to vanish all of them, but what Sherry was telling, that if some of them develops periregional edema, or if some of them develops hemorrhage, then that is what catastrophe happens, because over the time our brain adapts. So even if you have so many brain masses, maybe you won't have any other deficits because of neuroplasticity, but the real trouble starts when one of those lesions starts to leak, which means it starts to bleed or it starts to have edema. And that is when you start realizing that, okay, this person has been living with this ticking time bomb all the way along, but only now they're presenting with this some nystagmus just for 3 weeks. We know that this cancer didn't come in 3 weeks. So what actually happened? So this is what could have happened, that one of the lesions could have enlarged or could have had edema. And sometimes dexamethasone helps, but again, dexamethasone will help temporarily. So you need to go for the underlying cause, and hopefully one of these treatments can cure this patient. So thank you so much, Sherry. It's an amazing case. Yusuf, any final reflections?
The final reflection is that how the nystagmus here was a big sign. I had like a similar case as well with a patient on night float who just had a headache and they had the vertical nystagmus, and then the imaging showed like an intracerebral hemorrhage, and it can be a quick, easy exam, and you can find localized to the CNS. So we can give it the mic to Khashi, or if I think the reflections are over.
Okay, thank you so much. Amazing case. Lots of learning and reflection to do. The cases start with an approach to unsteady gait, and we learned that uh, it, unsteadiness in gait can happen anywhere along the pathway of the walking, and it's way more complex than we usually think about it. So, just to summarize, where should we think about localization? It can be anywhere from sensory pathway to motor pathway, neuromuscular junction to synapses, the CNS itself. A key to starting the localization is to understand whether the lesion is a lower motor neuron lesion or an upper motor neuron lesion. Afterwards, we move on to the physical examination, which gives us our first initial clues to localization. The dysmetria in gait disorder pointed us to the cerebellum, which we could localize within it using other findings we did in physical examination. We can localize to the vermis of the cerebellum using by findings like truncal ataxia versus in the hemispheres which present themselves as dysmetria and dysarthria and tremors. Then we saw weakness in the patient. Here, the first question that popped up was whether this is a multiple lesions causing the presentation or a single lesion. We usually like to think in terms of a single lesion causing everything, but just like this case, multiple lesions can present themselves. The patient had a history of AFib, which made them more likely to present with multiple lesions. But here, interestingly, we saw a rare diagnosis of glioblastomas, which is perhaps the exception to the primary brain neoplasms that present as multiple lesions. We usually see the brain lesions like this that are neoplastic as when they're presented with multiple lesions as metastatic lesions, but this is one of the rare cases here. Another important finding in the physical exam was the nystagmus. Nystagmus can present in two ways, vertical and horizontal. Horizontal usually points to a peripheral cause, while vertical is pretty specific for a CNS pathology, which was key to localization here, and it specifically points to brainstem and cerebellum. Reflexes was another thing that kind of helped us in identifying where the lesion was. Here, it pointed us to the second part, localization and time course. The time course of the event made it so that it's uncharacteristic to see hyperreflexia if this was a cerebral lesion in the cortex. So, we went on to understand the time course. Here, we were faced with a big with a big list of a differential diagnosis. Two most important ones were vascular and infections. Vascular causes are very important because they are, first of all, really common. Second of all, understanding their time course can affect how we manage them, and they need to be ruled out initially. In this case, we know that vascular causes have their highest intensity at the beginning, and we don't usually see a progression over the next few weeks, which made us go away from vascular causes in this case. Infections have a wide variety of diagnoses, same with autoimmune causes, paraneoplastic causes, deposition causes, tumors, and genetic causes, plus dystrophic disorders. Having this big differential in mind helps us navigate the various findings that may come up during our workup of the patient. And finally, going back on patient history, two other important factors here were the medications and the history of diabetes. Medications, especially the over-the-counter medications, can make the patient more prone to certain events. They can have anticholinergic effects, they can have symptomatic effects, they can result in hypercoagulable states, or they can lead to heavy metal toxicities. The diabetes itself made the patient prone to risks like diabetes neuropathy, lumbosacral neuropathy, and microvascular infarcts in the brain. I hope I've been able to capture the case thoroughly. Thank you so much.
Thank you so much, Khashir. What time is it for you right now,
4
Khashir?
a.m.
Oh
4
my
a.m.
God.
Oh my God.
My head would be spinning right now. Well, thank you for your dedication.
Thank
Sherry,
you.
any last words?
Just to think, I guess like for the last words is that everyone starts from some point. You're more than capable of being a physician and being able to make these diagnoses. You may or may not be a specialist, but there's some key things that you will be able to think of that will help you point to the right direction as far as what you're going to order so you can take care of the patient as best as you can. Because I am sure not a neurologist, but I knew specifically that vertical nystagmus, there's something going on with his brain. And without having, he didn't really have, I mean, he had some cerebellar issues, but the vertical nystagmus is what gave it away for me. And that's also how we got to the diagnosis. And once you're able to do the diagnosis, you're able to basically manage it, get the specialists that you need to be seen, such as hematology and oncology, neurology, neurosurgery, and then go from there. And you are more than capable of doing that. So don't be shy or afraid that you may or may not know a diagnosis. You still have to trust some of the basic things that we learned in med school to help you come up with the right diagnosis. So I wish everyone the best of luck and a great night.
Thank you, Sherry, and good luck on your shift tonight.
Thanks.
Hope you get us some new cases for next week. Thank you. Have a wonderful evening.
Thanks, you too.
Bye, everyone.